Hello, I'm hematologist-oncologist Dr. Tony Talebi. Today we're going to discuss bladder cancer. I have the pleasure of being with Dr. Mark Soloway, Professor of Urology and longtime chairman at the University of Miami. Dr. Soloway currently chairs an international consensus group to generate recommendations for the treatment of bladder cancer, so he truly is a world-class expert in bladder cancer. Thank you for being here.
My pleasure.
Okay.
Yeah.
Dr. Soloway, what is bladder cancer?
Bladder cancer is a malignancy, but a heterogeneous one, meaning that there are bladder tumors which barely can be called cancer because they don't spread, but they recur locally. That is, an individual once getting a bladder tumor is highly likely to get another one, at least 50% chance. We can go into the reasons for that later on. So it is an abnormal growth in the lining of the urinary bladder, or in a sense the same kind of tumor can develop anywhere along the urinary system. And this growth has different potentials depending on a variety of factors called the grade, the aggressiveness, etc.
You guys often use a term called upper pole versus lower pole urothelial cancer. What does that mean?
Well, we use the term by the anatomic structure which is involved. So it can be a renal, kidney, urothelial cancer, used to be called transitional cell carcinoma. But the current term, the better term, is urothelial. Urothelium being the lining of the urinary system. So it's a cancer derived from the urothelium. So we call it urothelial carcinoma of the urinary tract. That would be the best way of putting it. Now, the urinary tract can be in the collecting system of the kidney, where the urine collects before it goes down to the ureter, the tube that takes it to the bladder. Can form in the bladder, these tumors, or in the male, it can form in the first part of the exiting tract from the bladder, which is the prostatic lining or urothelium, and then through the urethra. So these tumors can develop anywhere. They're most likely by far to develop in the urinary bladder. Makes sense. If there is a cancer producing substance in the urine, for example caused by cigarette smoking, be the best example, probably that urine contaminates or sits in or dwells in the urinary bladder far more than it does up in the kidney.
I see. So you alluded to the fact that the quote-unquote the cancers can come back. Would you please explain what field cancerization means?
Well, I think the best analogy is for most people who are familiar, particularly as they age, getting cancers of the skin, face, from sun exposure. So it's exactly the same situation. So if you're in your 20s and 30s, you love to go to the beach, you're out in the sun, you could care less what's going to happen 50 years from now, then it comes back to haunt you, and you can get a cancer here, and then 5 years later another one here, and you have to have them individually removed. So it takes many years for those cancers to develop. Ergo, if you were exposed to a cancer-causing agent from some manufacturing process, or from cigarette smoke, which we know causes bladder cancer, it may take 20, 30 years for those cancers to develop. And they may develop at one part of your bladder on March 2008, that's removed, and then 6 months or a year later, that same process caused a tumor in another place. So that's why we call it the field change, because that carcinogen, that cancer-causing agent, is altering the lining cells of the bladder or the kidney for that matter over periods of time at different rates.
I see, wow. So what are the symptoms one can experience with bladder cancer?
The most common presenting complaint is, wow, my urine is bloody. Blood in the urine is the initial factor that brings a man or woman to the doctor because of some blood, obviously in the urinary tract. Could be from the kidney, could be from the ureter, could be from the bladder, could be from the prostate, anywhere along that tract. We might, just to get an idea of the anatomy, I don't know if they can view it, This anyone can get for free, and we can talk about this later. This is Bladder Cancer Basics for the Newly Diagnosed. It's a free little brochure from the Bladder Cancer Advocacy Network. But if one can see here, Tony, you can see the kidneys, the ureters, and the bladder. The bladder is down here, of course. And so these tumors can develop anywhere along the urinary tract.
I see. So you mentioned smoking, but what other risk factors predispose one to developing bladder cancer?
By far and away, smoking is the most common one. There are other, for instance, beauticians, more likely to get bladder cancer, firefighters. Is there a common denominator? Probably they're involved with chemicals on their hands. That their chronic exposure, these chemicals get in through the skin, and they are concentrated in the urine, and they are cancer-producing compounds.
I see. For our patients watching in the Middle East, there's an infection that can predispose one. What is that?
This is primarily in Egypt, and it is due to a protozoa called schistosomiasis, or bilharzia. And these protozoa can get into the lining of the urinary bladder, cause chronic infection. Also, these people are somewhat malnourished. The combination of this chronic infection can lead to bladder cancer.
I see. Is there any...
And I should indicate that, as you brought up what other inciting factors, chronic indwelling catheter, chronic infections of the bladder, possibly also can cause bladder cancer over time. So one population that's particularly concerning is those with spinal cord injury, because they don't empty their bladder well or have an indwelling catheter. So again, chronic infection. But they tend to be squamous cell carcinomas, not the standard common urothelial cancer that's caused by, most cases, smoking.
I see. What are the different types of bladder cancer? You mentioned squamous and urothelial.
There are three types. Over 90% are urothelial carcinoma, which can be broken down to grade 1, 2, or 3, or low grade, high grade. That's the pathologist's interpretation of how aggressive they are. So most of them are urothelial, formerly known as transitional cell carcinoma. And then a few percent are squamous cell carcinoma or adenocarcinoma of the bladder, and they act differently.
So does that have different therapeutic implications for the patient?
Indeed. The response to chemotherapy, the response to radiation therapy is not as good for the adenocarcinoma and the squamous cell. So fortunately for us and our patients, of course, the more common type, 90% are urothelial cancer, and they do respond to chemotherapy often, they do respond to radiation. And of course, surgery is a very important part of the treatment.
Is there any evidence that the term chemoprevention or taking vitamins might prevent bladder cancer?
Probably the quick answer to that is no. I'm not aware that there's any vitamin that you can take that will, let's say you smoke for 20 years and you say, I want to get rid of that potential problem. Other than stopping the smoking, there's nothing you really can do. Why
do men develop bladder cancer more than women?
I'm not certain, but I suspect a lot of it, men tend to smoke. As women smoke as much as men, they develop. It's pretty uncommon to talk to someone who has bladder cancer and find out that they never smoke cigarettes. It does occur, but it is distinctly the vast minority that do that. So the majority have had a history of cigarette smoking.
Okay. Is there ever a time when a patient or their family needs to seek genetic counseling if they've been diagnosed with bladder cancer?
I don't think so.
Okay. Now, how is bladder cancer staged?
Bladder cancer is staged by the depth of invasion into the wall of the bladder. So we start out with a cancer confined to the surface. We call that T. T as in Thomas, A. A cancer that starts to spread into the first layer, the lamina propria, is T1. And a key parameter is once the cancer is into the muscle wall, it's T2 or T3, and then through the bladder would be T4. So the depth that it has grown is the key to staging, and the staging, of course, identifies what is the proper treatment.
I see. So this is so important. You talked about superficial bladder cancers versus invasive. What do those two terms mean?
Well, the first thing is don't use the word superficial bladder cancer. I've written a couple editorials, and I think it's pretty much changed around the world not to use that term. The reason is the term, quote, superficial bladder cancer referred to tumors that were TA and T1 together. But clearly a TA and a T1 are vastly different cancers. A TA low-grade tumor will not kill anybody. And I often, when I lecture to the urologists, and I say, don't overtreat people with TA low-grade tumors. Don't injure their bladders. Don't give them too much treatment, because at the worst, they will come back. But they often can be taken care of just right in the office without even going to the operating room. Sometimes if they're very teeny, you can just watch them because they're never going to spread. Whereas a high-grade tumor, be it TA, still confined to the surface, or if it has started to invade into the wall of the bladder, they are much more dangerous.
I see. So then what term would you use instead of
I talk about the grade and stage. That makes it very easy. So if you're discussing a patient, so for instance, Tony, you would say, I want to talk to you about a patient with TA low-grade tumor and he's had such and such treatment, or I want to discuss a patient with T1 high-grade tumor, he's had a resection and now it's come back. Now I know exactly what you're talking about. But if you alternatively you say, this patient had superficial bladder cancer,
it doesn't.
I don't know whether it's in a good category or a more aggressive tumor.
I see what you're saying. So let's just take a step back. Assuming a patient has had blood in their urine, they went to their primary care doctor, and then they get referred to you. What happens next for that patient?
Well, anyone who has blood in the urine, be it microscopic or they overtly see obvious blood in the urine, first of all, that subcategorizes them. Clearly, if someone has obvious blood in the urine that they see, they're startled, they're afraid, they come to you right away. According to our current guidelines, open to revision and some judgment, is that one should evaluate the entire urinary tract to make sure that there's no cancer that is causing the blood in the urine. Of all of those with, we call it gross hematuria, where you can obviously see the blood in the urine, as opposed to microscopic, where it's just look under the microscope and you see some red cells, or you use one of these dipsticks and see red cells. So if you have gross hematuria, the likelihood of a cancer being a cause of that is more likely. However, only about 3%, maybe 5% of all those with hematuria, cancer is the underlying cause. But nonetheless, as a physician, when someone comes, you want to exclude cancer. They're thinking, do they have cancer? And clearly you want to be able to tell them. And you can do that with x-rays. So ordinarily we would order a CAT scan to evaluate the kidneys, the upper urinary tract, meaning the renal pelvis, the other part of the kidney, because it could be a tumor not related to the urothelial lining, but what we call a renal cortical cancer. That's a bulge on the kidney, which is a different subject. And then we will want to look in the bladder, procedure we call a cystoscopy.
Okay.
So we can do that in the office. It takes about 5 minutes. It's really borderline painless. Nothing. It's always easy for the doctor to say it's painless, but really is not uncomfortable. It's very quick. We use a little local anesthesia. In the female, of course, they barely feel it. Even in the male, we have what's called a flexible cystoscope. So it easily passes right in through the urethra into the urinary bladder, and we can evaluate the entire lower urinary tract to see what was the reason, if we can find anything, for the blood in the urine. So we can evaluate the urinary bladder to see if there's any tumor. We can evaluate the prostate. Often in the male, the blood is just from a blood vessel breaking on the surface of an enlarged prostate.
I see. So if in order to receive a cystoscope, what does the patient need to do the night before, and when can they return back to work?
There is no problem, no, nothing. This is not like a colonoscopy. No clean out is necessary. You just show up at the doctor's office and you have the procedure and you go home.
Do they need to be accompanied with someone else? Or
No, we don't give anything that would alter their sensorium, etc. It's only a local little minor procedure.
Okay. So let's say now you put the scope and you do find that you see a mass. What do you do?
Well, once you see something, urologists are pretty darn good at saying that's a tumor. It's a growth. So the next thing to do is go to the operating room. Usually it's a fairly brief procedure, almost always under an hour. Patient has a general anesthetic or a spinal anesthesia, and one has a special instrument called the resectoscope. This is now a rigid scope which goes in through the urethra. It has a curved loop at the end of it, which is attached to cautery, and one can very safely, meticulously remove the tumor, sends it to the pathologist for interpretation, is this cancer or not, and then of course the grade if it is cancer.
So let's say you send the specimen to the pathologist and he or she tells you that the muscle has not been invaded.
Well, the first question, is it cancer, yes or no? Secondly, what is the grade of the cancer and the type? Is it urothelial cancer, adenocarcinoma, squamous cell carcinoma, or some other unusual type? So those are the things you want to know. And then if it is a tumor, has it involved a wall of the bladder? And what's the depth of invasion? So in order to determine, obviously, whether the tumor's in the muscle, there has to be muscle there. And is the cancer invading or through or encompassing part of the muscle? And then the treatment would vary dramatically depending on the extent of invasion.
Okay, so let's first talk about, let's assume that the tumor has not invaded into the muscle. What do you do if it's low grade?
Well, if it's low grade, then it's confined to the surface. You have a choice. Either it can be removed and just follow the patient. Most studies suggest, however, that after the removal, within hours, in the recovery room, we put an active chemotherapy agent into the bladder, because during the course of the procedure, when you're in there and you're removing tumors, tumor cells are floating around this organ, which is containing urine, of course, constantly coming down from the kidneys. But I actually proved many years ago in an animal model that these tumor cells can stick to the surface of the bladder if the surface is altered. Well, you've altered it by the resection. So therefore there's like an ulceration. So the tumor cells floating there can stick there, and in 3 months there's another tumor there. Because the tumor that you just thought you totally removed, some of them stayed behind. So if you put chemotherapy into the bladder, you can do it very safely, as long as you didn't make a hole in the bladder, which we rarely do. And then that stays in there for about an hour. It kills those residual cells. We call that intravesical, meaning into the bladder, chemotherapy.
So that's interesting. So you do that every time?
We try and do it almost every time we've removed a tumor. It can be done in the office too. When we cauterize a very small tumor in the office, to any residual cells, they will be then destroyed with the chemotherapy.
So then how do you follow that patient in the coming months?
We're going to see that patient approximately 3 or 4 months later.
Okay.
If there's no cancer, then we will delay the next visualization of the bladder with office cystoscopy for now several months, could be up to a year or so.
I see. So now let's take the same scenario. Let's say the tumor has not invaded into the muscle, but it's now high grade. How is that different?
A high-grade tumor, be it TA or T1, again, we would put in the chemotherapy, 1 dose, just 1 dose. Patient comes back in a couple of weeks, we review the pathology, we say, okay, you have a TA or T1 high-grade tumor, and then it has been shown that there is a medication that can be placed into the bladder again, weekly for 6 weeks, which is called B as in boy, C as in Charles, G as in George, BCG, which stands for the people that basically invented this attenuated bacteria, which, as many people know, is used to prevent aggressive tuberculosis. So people get immunized. It's a very safe compound. Everybody in Canada and Europe used to get it as a vaccine. Well, what happens, this stimulates the immune response. And if the BCG is placed into the bladder, stays there for an hour, then it attracts the cells in the body, type of lymphocyte, that associated with that can identify tumors as foreign or malignant and potentially kill them. So this BCG medication is put in the bladder weekly for 6 weeks, and then we wait a period of time, and then 6 weeks later, approximately, we evaluate to see if there's any tumor in the bladder.
And can this procedure be repeated over and over?
Well, it can be, of course, it can be repeated over and over. First of all, there's some minor side effects associated, but nothing major. if it either generally works or doesn't work. If it doesn't work, you don't want to keep repeating it, because then the tumor can continue to develop and grow and eventually spread or become very aggressive in the bladder. So there's a lot of judgment in how often to give it. But about 50% of people respond exceedingly well to the combination of removing whatever tumor you see plus the BCG. And one never knows when you have a success, would that tumor have come back again without the BCG? So therefore you do randomized studies. Half of the people get BCG, half do not, and you see at the end of the day how many are free of cancer. And clearly there's an advantage to receiving the BCG.
What are the side effects?
The side effects of BCG, it's a flu-like symptom, which often lasts up to 24 hours, urinary frequency, so it irritates the bladder. It's like getting an infection in the bladder, but usually resolves pretty promptly within a day or two.
And how do you assess whether it's been a treatment failure? What tells you it hasn't worked?
That there's cancer back in the bladder.
Okay, I see. So now let's assume that you took the biopsy and now the pathologist calls you and tells you that the muscle has been invaded. What happens next?
Well, now we call this a muscle invasive, they're always high grade, urothelial carcinoma. So there are many, this is not a short answer, and this is a long discussion with the patient and hopefully the family who will help make this decision. So the first thing is to what stage the tumor. Has it spread to the chest? Has it spread to the liver, lymph nodes, etc.? So you get a chest x-ray and a CAT scan. And the urologist got a pretty good idea whether they're likely to have spread just from looking at the original tumor, how extensive it was. I should add, and this is a very important point, there often is a major delay from the time men and women with muscle invasive bladder cancer develop the tumor and had symptoms until they finally get a diagnosis. This is a major, major problem. And the reason is twofold. One, that particularly in women, they have blood in the urine. What happens? They go to their gynecologist or primary. And what does the primary think? You have a bladder infection, because they probably have had a bladder infection. And women, when they see blood in the toilet bowl, aren't as concerned as men would be freaked out.
Right.
I mean, wow, I got something bad. But women, okay, I've seen this before.
Right.
So they tend to, it's probably an infection. So they can go 2 or 3 or 4 months. Getting an antibiotic, initially the bleeding may stop, right? Because the tumor cells that cause the blood vessel to break, that healed a little bit. The cancer's still growing, but not bleeding, or the patient doesn't see the bleeding. So there often is a delay on the patient's part, but also on primary doctor's part, getting to the person to a urologist. And this can happen in men as well. Or, like many other cancers, they just aren't a lot of symptoms until they bleed. They don't have pain. They may have some minor urinary irritative discomfort, but very vague. So this is a dilemma. And we can talk about, are there ways, if someone was at high risk, like a cigarette smoker, to find cancer earlier? We should try and address that. So again, I think that's important preamble. So we do the staging studies, and let's take this particular patient you're asking about. They're all negative. So he has, let's say, 65, good health, expected to live many, many years, good heart, good lungs, etc. The choices are the following. One, standard, probably best treatment is removal of the urinary bladder, and then a urinary diversion, which we'll talk about in a minute. We remove not only in a male the bladder, but also the prostate, because remember, the same lining of the bladder is in the prostate. So if you left the prostate, there would be an opportunity for later development of the same kind of tumor in the prostate. So that would be obviously require major treatment, again, possibly additional surgery. So you don't want to leave that opportunity there. So that's the first choice usually. Now there's another choice, which is bladder preservation, which we can get to in a minute. And then the whole subject is, should chemotherapy play a part in the treatment?
Exactly. When do you decide whether to develop a neobladder or do a diversion?
So once we remove the urinary bladder, so you have a couple possibilities what do you do with the urine? Because the bladder has been storing the urine.
Exactly.
Now what are you going to do? So there are two possibilities. One is called an ileoconduit, and that developed in 1950s. Before that, what they used to do is take the urine and put it into the bowel cavity. The problem is chronic infection, and people survive but not very happy. So in the early 50s, actually a general surgeon named Bricker, B-R-I-C-K-E-R in St. Louis, said, I'm just going to take an isolated piece of the bowel tract and sew the two ureters, one from each kidney, into this, and it will come out as a stoma. And you'll have a little appliance in the abdominal wall and collect the urine. And actually, that's still today a very commonly, probably the majority of men and women have what's called a Bricker procedure, or ileal, I-L-E-A-L, ileoconduit, because we use the ileum as the part of the bowel that's going to have the urine initially placed into it from the ureters and then exit right out. But that's non-continent. In other words, the urine continues to come out, but you could have one on, I could have one, and no one would know it. You can swim, you can do whatever your normal life is like. Several years later, over time, people said, well, why can't we make a pouch, if you will, and bring it to the urethra in a male or female? Then they could urinate. Now, it's a little bit trickier to do. We call it an orthotopic, because it's going to be where the bladder was, neobladder or new bladder. So we're going to take more of the bowel, but not a consequence to the individual. We're going to reconfigure it into a bladder shape, and we are then going to suture it to the remaining urethra. And actually it works very well. There are some minor trade-offs between the two, which we have to go over with the patient. And what I always do is say, look, I'm going to give you a list of people that have had the ileoconduit and a list of men and women who've had the neobladder. They have to deal with this. You talk to them and see which you think would be best for you.
In your experience, who are the happier patients?
Many studies have looked at this. People are pretty darn happy with it, whatever they chose. And we never switch. You got one time to decide. We're going to do that at the time of surgery. We'll try and do what you asked for.
Is there ever a time when it's not possible to remove the entire bladder?
Well, if the cancer is too extensive and you would leave cancer behind, so occasionally, it's not very usual. Most of the time we intend, based on our staging studies, the CAT scan, we think we can remove the bladder, then we will remove the bladder.
I see. And is there ever a time when you could have muscle invasive disease, but you opt to leave the bladder in and only resect part of the bladder?
You would only do well, there are two answers to that question. The first is, can you just do what's called a transurethral resection and be confident that you removed all the cancer? The odds are strongly against you. Of course, no one wants their bladder and prostate removed, or women don't want their bladder removed and have a bag on the side, or the neobladder makes it much more comfortable and palatable for many of them in terms of quality of life. But nonetheless, this is a major undertaking and somewhat of a quality of life alteration. The problem is, you can hope for a period of time, but the cancer, again, the cause of the initial cancer is likely to bring its ugly head up again. And another tumor is highly likely to develop.
I see.
And if you wait too long and the cancer spreads, we have no cure. That's the key.
I see.
Once bladder cancer is spread to other parts of the body, chemotherapy can be palliative, can help a lot of people, but rarely will provide a cure.
I see. So what are the complications of these surgeries?
The complication rate is rather high, but it's fortunately, let me give you some statistics. The likelihood of dying from these operations is only about 1 or 2%, unless a person has a lot of problems with the heart or lungs, something that really makes the surgery more dicey. So it's pretty low. The chance of some complication, but it's usually infection, urinary tract infection, what we call pyelonephritis, infection from the kidneys because of the manipulation, a wound infection, delayed getting out of the hospital, relatively minor comparing what we're doing with this major 5-6 hour operation. So it's a pretty well tolerated procedure, I would
see.
guess.
Now, is there ever a time where you...
I should add, this is one operation I think should be left in the hands of men and women surgeons, meaning that do this every day.
I agree.
And in a hospital which has an excellent intensive care unit, has very good anesthesia, this is not for someone who does this once or twice a year.
I agree.
And frankly, most urologists who do this operation will not want to do it because you have to take care of these people for that first week, 7/24. It requires good medical care, intensivists, hospitalists, as well as the operating surgeon who's done this a lot. So, and I think that's increasingly stressed. However, if you look at the statistics, even in the United States, a high percentage of men and women with muscle-invasive bladder cancer do not get evaluated at a tertiary care center. And part of it is they're elderly, and they don't want to leave their area.
I understand. But it is a very serious procedure. I agree. I've seen it myself. What is the role of chemotherapy with muscle-invasive bladder cancer?
This is a tough one because there's not overwhelming evidence what is best. So the answer is, I'll give you my philosophy and where the debate is. So the first is we have shown that systemic, we call it through the vein chemotherapy, has a role in bladder cancer. There are several drugs which can kill bladder cancer cells. Usually not everyone in the body, but they can kill a lot of cells. And people will live longer if they have chemotherapy, and we can see tumors shrink. These drugs work whether the tumor is spread to the lung, the liver, or whether the tumor is still in the bladder, but an aggressive tumor. The question is, we have reached a plateau of how many people we could cure by just removing the bladder. Why? Because some cells have gone beyond the confines of the bladder or have spread to other organs in the body. So more surgery is not going to cure more of these people. We need something in addition, and that could be chemotherapy. So there have been several studies that have taken men and women with muscle-invasive bladder cancer, and they have either received chemotherapy, not chemotherapy in the bladder, but through the vein, so it reaches the entire body, also the bladder, before surgery, compared to those who went directly to the operating room without any chemotherapy. And then they would get chemotherapy later if the cancer recurred. And there is about a 5% survival. 5% more people will be cured of their bladder cancer if they receive chemotherapy in the beginning.
I see.
Now the controversy. So the next question is, well, does everybody now use this? Is this standard? And the answer is no. Only about maybe 50% of experts like myself who do this every day have adopted this as standard treatment. Even though the recommendations from our international guidelines, we strongly recommend it. Other bodies, the European Urology, the American Urologic Association, say it should be seriously considered. Here's the data. And their thinking is that, geez, a high percentage of people are going to be getting this chemotherapy and it won't help them. Let's just go ahead and take out the bladder, see what the final extent of the cancer is, and then decide who needs chemotherapy. We save chemotherapy from a lot of people. There's one major issue I have with that, and that is, if you take someone, and the average age of someone who has this major operation for bladder cancer approaches 70 to 75. It's not people in their 50s or 60s as a rule, although of course it can happen. You put them through major surgery, and then you now go to them and say, you know, I think you need chemotherapy. It's going to take them 4 to 8 weeks just to get over this major operation, to feel strong to even talk to you about what additional treatment. So the likelihood that they're going to get adequate chemotherapy on a reasonable schedule, that means getting started in a time when it can help them, is far less than if you start out in the very beginning when they haven't had major surgery. They're getting ready for this course of treatment and say, you know what, we can give you 2 months of chemotherapy. We're going to kill a lot of that cancer. It's going to make your surgery potentially easier. And there is this 5% better chance that you have to be cured. Now, as you know, Tony, in other cancers like breast cancer, all the oncologists and all the medical oncologists have adopted this as standard treatment.
Right.
So it's a long explanation. I am in favor, particularly if you have a cancer that is shown that it's probably through the wall of the bladder deeply, and we can identify those. I stress, I think you should see a medical oncologist, begin chemotherapy, and then in after a couple cycles or 6 weeks, let me look in your bladder, see if it's working. I can tell if it's working. And if it's working, you get one more cycle of chemotherapy, because we're gaining ground here, and then we take you to surgery. If it's not working, say, okay, it's not working, let's go ahead and remove the bladder. No more chemotherapy is going to be beneficial.
I know you're not a medical oncologist, but you probably know this better than any of us do. Do you prefer the chemotherapy regimen called MVAC or gemcitabine cisplatin?
Well, that one is easy, because because of, in metastatic disease, the gemcitabine cisplatin has been shown to be equivalent with less side effects, as you know, to the MVAC or MVAC. And we have to thank someone. I always look back in history, who do we thank for these advances? And there's a fellow named Alan Yagoda, Y-A-G-O-D-A, he's now deceased, who worked at Memorial Sloan Kettering for many years and then on to Columbia University. He is one of the leaders, the pioneers of chemotherapy for bladder cancer, and he developed the MVAC along with now his fellows at the time, Cora Sternberg, who's in Rome, and Howard Scher in New York. And that was a landmark because it showed that combination chemotherapy can really help people with bladder cancer. And so the bottom line is gemcitabine cisplatin, equal efficacy, less toxicity, pretty well tolerated. That's what we tend to use.
Now, when would you actually recommend, instead of surgery, radiation and chemotherapy?
You're probably asking the wrong person. The radiation oncologist would recommend it more than I would. So yes, why is this controversial? Shouldn't you all get together in a room and fight it out and say, okay? The first, actually that's a simple answer. Those who believe that the bladder can be preserved in patients with a muscle-invasive bladder cancer, there are certain criteria that have to be met. One, no hydronephrosis, no blockage of the ureters, because that identifies cancers that are clearly grown deeply into the wall of the bladder. A usually solitary tumor, not multiple tumors. And very importantly, and they stress this, the urologist should have resected all of the tumor that they can see in the bladder. We call it a, quote, complete TUR. Now, if you ask me what percentage of patients meet those three criteria, it's probably only about 10%. And I've looked that up. So the majority of people don't fit that category. Now, those who have three specialists who believe in the concept, it requires a urologist to do the complete TUR, an excellent radiation oncologist devoted to this, and thirdly, a medical oncologist who's experienced with the chemotherapy. Working together, this presumably, in data from the centers that have really approached this, can preserve the bladder in approximately 50%. Now, still some of them are going to fail, and there are points at which they check the bladder. If the cancer's still there, and then they go ahead and remove the bladder.
I see. So it doesn't matter what the patient's age is or their performance status. It's really those three criteria that you look at?
Mostly, yes. Yes. I mean, clearly, if they can't tolerate surgery, then you have to look for an alternative. And it may be palliative radiation, but it often will be palliative. It may not work because so many of the patients are in this category.
I see. And what is this hemorrhagic cystitis that can happen with radiation therapy?
Fortunately, if you asked me 15, 20 years ago, I'd say, oh, that's radiation really causes this problem, etc. And it's because of cobalt radiation, not well-directed radiation, radiation which was too high a dose, etc. And that's just increased blood vessels within the bladder caused by the insult of radiation therapy. But nowadays, the likelihood of that is really very unlikely, thankfully.
I see. Sometimes I've seen patients where they bleed continuously from their tumor. What can be done in that scenario if a patient's continuously bleeding?
Well, we don't see those. If the bladder is out, then that's not going to...
Let's say if the tumor is still in.
Yeah, I'm saying that the treatment is to do a transurethral resection, and then, I mean, the likelihood that a patient's going to die of bleeding is pretty darn... I don't know if I see one patient like that in 10 years. That's
very rare.
In the United States and Western Europe, modern medicine, very, very unlikely.
What do you tell family members of patients with bladder cancer?
One, if any of you in the room smoke, stop smoking. Pass that on to your children, your grandchildren, etc. That smoking can lead to this life-threatening condition. It's amazing how few people know, and doctors included, that smoking is a risk factor for bladder cancer. I mean, one of the things I stress when I speak to primary care physicians, and I said, if someone walks into your office and they have acute chest pain, 911, emergency, into the hospital to get cardiac cath, it should be exactly the same. Someone over 50 smoked for 15 or 20 more years and they have blood in the urine, you get them 911 to a urologist to check them out for bladder cancer, or at the least do urine cytology. So I tell the bladder cancer, let's all go through, get one of these books, go to the website, Bladder Cancer Advocacy Network. Now they can go to your website and learn about bladder cancer, and we can gain some understanding what the best treatment for that individual is.
I think patients with cancer, what they want from us the most is hope. How do you give your patients hope?
You know, I was told that very early on in my career, that that's important. And certainly as we, year by year, we have more advanced treatments, we have safer surgery, that's for sure. We have the opportunity to give almost every patient hope. Even if the cancer has spread, we have now better chemotherapy. The side effects from chemotherapy are much less than they used to be. And as a urologist, the good thing is for all the cancers that I deal with, be it kidney cancer, bladder cancer, prostate cancer, the great majority, we have a very good opportunity to cure them. So I'm pretty lucky at the end of the day. We cure a lot more patients than we did before, and the great majority can be cured of their disease.
That's wonderful. Well, thank you so much.
Super.
Thank you for watching. We hope this has been educational for you.